I would like to thank Dr. Andropoulos and the organizers for giving me the opportunity to present our recent work focused on the development of novel class of general anesthetics referred to as neuroactive steroids. I'm truly honored to be here and only sorry that we cannot be together in person. I have no conflicts of interest to disclose. The neuroactive steroids I would like to focus on today are the ones based on progesterone ring, shown to have hypnotic properties. The pharmacology of steroid anesthetics could be modulated by substitution of hydrogen bonding groups at various positions, resulting in their effects ranging from GABA potentiation to blocking the voltage-gated calcium channels. Although we've been studying all of these neurosteroids, my talk today will focus on three of them: alfoxolone, 3-beta-hydroxy, and CDNC24. We began our assessment of the in vivo effects of these neuroactive steroids by studying their hypnotic properties using the loss of writing reflex, a well-known model of measuring sedative effects in rodents. We started our dose response studies with 3-beta-hydroxy and compared it to ketamine, a commonly used intravenous anesthetic in pediatric population that is known to be neurotoxic to a very young brain. As you can see, both 3-beta-hydroxy and ketamine cause dose-dependent loss of writing reflex in 7-day-old rat pups, with the ED50s being comparable around 4 milligrams per kilo. Based on the LD50s as shown in this insert, the therapeutic index for 3-beta-hydroxy was around 20, and for ketamine was around 23. We use 7-day-old rat pups since this is when their brains are at the peak of vulnerability to anesthesia-induced developmental neurotoxicity. Since the neurotoxic dose of ketamine was published to be at 40 milligrams per kilo, we calculated the equipotent dose of 3-beta-hydroxy based on our loss of writing reflex experiments and concluded it to be 10 milligrams per kilo. Similar dose response studies were conducted with two other neurosteroids of interest, alfoxolone and CDNC24. But this time, our proxy was propofol, another commonly used intravenous anesthetic in pediatric practice, also known to be neurotoxic to a very young brain. The calculated ED50s are listed above each dose response curve. It is interesting to point out that although there was a dose response mortality observed with alfoxolone and propofol, we did not detect any with CDNC24 up to 60 milligrams per kilo, which was the limit of its solubility. As shown in the therapeutic index table, the irony is that propofol, clinically used anesthetic, has the lowest index when compared to alfoxolone and CDNC24. Since the neurotoxic dose of propofol was published to be at 20 milligrams per kilo, we calculated the equipotent dose of alfoxolone and CDNC24 based on our loss of writing reflex experiments and concluded it to be 10 milligrams per kilo for both. To assess the neurotoxic potential of these neuroactive steroids, we started with 3-beta-hydroxy and looked at several brain regions. As you can see on this slide, 3-beta-hydroxy-induced caspase-3 activation is very comparable to its vehicle. Whereas there is manifold increase in caspase-3 activation induced by ketamine when compared to 3-beta-hydroxy or its vehicle saline. This type of effect was noticed in all brain regions that we studied, CA1 in subiculum, 2 thalamic nuclei, and cingulate cortex. Based on these findings, we concluded that 3-beta-hydroxy does not induce developmental neuroapoptosis. Similar observations were made with alfoxylon and CDNC24, as shown on this slide. Both alfoxylon and CDNC24 induced caspase-3 activation that was very comparable to their respective vehicles, whereas there's manifold increase in propofol-induced caspase-3 activation when compared to its vehicle interlipid or alfoxylon or CDNC24. Based on these findings, we concluded that alfoxylon and CDNC24 do not induce developmental neuroapoptosis above and beyond what is observed with their vehicle. And you can see this in subiculum, as well as a couple of segments of medial prefrontal cortex. Considering the neurosteroids appear to be effective and safe general anesthetics in young pups, we set out to examine the functional outcomes by focusing on cognitive development in young adulthood. We use radial arm maze, a spatial learning task that is based on animals' ability to retrieve food pellet in each arm without going back to the one where they had already been. As you can see in panels B and C, ketamine animals took significantly longer to learn the task compared to their vehicle control saline. However, the learning abilities of 3-beta-hydroxy animals compared to its vehicle cyclodextrin was indistinguishable. Cumulative analysis of their learning capabilities indicated that there is a substantial gap in learning when ketamine animals are compared to either vehicle or 3-beta-hydroxy, suggesting, and here's a pretty big gap in learning, suggesting that unlike ketamine, 3-beta-hydroxy does not have detrimental effects on spatial learning, at least as assessed with radial arm maze paradigm. To begin to assess the mechanistic effects of neurosteroid anesthetics, we examined their effects on several cellular targets, both voltage and ligand-gated ion channels, and concluded that T channels may be an important ion-gated calcium channels worthy of further study. Because they activate with small membrane depolarization, they play an important role in controlling neuronal excitability. We know that the inhibition of T currents results in significant anti-nociception in a variety of animal pain models, and the T channels regulate sleep and wakefulness, and as such, they may exhibit substantial hypnotic potential. Our patch clamp studies show that 3-beta-hydroxy at hypnotic brain concentrations completely blocks T channel dependent firing in ventrobasal thalamic nuclei and in subicular neurons as well, suggesting that 3-beta-hydroxy hypnotic properties could very well be due to its T channel blocking effects. Now, what about GABAergic activity? Potentiation of GABAergic neurotransmission was suggested as the most likely mechanism responsible for neurodevelopmental anesthetic toxicity. Propofol, a GABAergic anesthetic, acts mainly postsynaptically and upregulates tonic GABA-A conductance. We have done extensive work looking at pre- and postsynaptic effects of 3-beta-hydroxy, alfoxylon, and CDNC24, And although due to time restriction, I will not be able to present the raw data, we concluded that 3-beta-hydroxy decreases spontaneous release of GABA. Interestingly, alfoxylon and CDNC24 induced postsynaptic potentiation of GABA-A receptors that is accompanied by significant suppression of spontaneous GABA release. In addition, due to its blocking of presynaptic voltage-gated calcium channels, alfoxylon suppresses both evoked and spontaneous presynaptic GABA release, thus taming the activation of postsynaptic GABA receptors. What seems to be crucially important here is that a fine balance between GABA release and the activation of postsynaptic GABA receptors is crucial in achieving general anesthetic state without causing the neurotoxicity. In conclusion, novel neuroactive steroids are promising alternative to currently used general anesthetics. T channels and presynaptic GABA release mechanisms could be very promising targets for the development of new anesthetic agents, where we try to find the agents that can strike a fine balance between releasing just enough GABA to cause general anesthetic state, but not too much to cause neurotoxicity. We should consider the development of new general anesthetics for use in pediatric anesthesia so we can continue to safely anesthetize our children. I would like to take a moment to express my utmost gratitude to very talented people who have over the years contributed to this important line of research. Also, this would be a good moment to acknowledge our funding sources that have been absolutely crucial for the generation of these data and the day-to-day function of our laboratory. Thank you very much for your attention.
Thank you very much for the invitation to speak here today, and good afternoon from New York. My name is Viola Neudecker, and I'm an associate research scientist at Columbia University. Today, I would like to talk about the major findings from our two recently published studies in juvenile non-human primates after early life anesthesia exposure. I have nothing to disclose. As you all know, there's a concern and a controversy whether the exposure of young children to general anesthetics affects their neurobehavioral development. Some studies report associations between early in life anesthesia exposure and learning disabilities, deficits in general intelligence, and increased risk for attention deficit hyperactivity disorders, while other studies report none. Certainly, such controversial findings are not surprising when thinking of these studies being in majority retrospective, very heterogeneous, and containing several confounders. In contrast, there are results from 3 studies with prospective assessments that Dr. Ng combined in his recently published meta-analysis and confirmed that a single early in life exposure has no risk for deficits in IQ, but based on observations made by parents and caregivers at home or at school, exposed children have an increased risk for internalizing behavioral problems. Studies in animals also report long-term functional impairments after early in life anesthesia exposure, such as impairments in learning and memory and alterations in behavior. In juvenile non-human primates, alterations in behavior reported include increased anxiety-related behaviors. However, in contrast to the behavioral alterations reported in children, these behaviors in non-human primates have been detected by provoked testing. In addition, structural changes reported in brains of animals exposed early in life mostly relate to the acute injury, such as neuroapoptosis. In contrast, we know very little about long-lasting structural changes. So we asked 2 questions. Does early in life anesthesia exposure alter spontaneous behaviors of juvenile non-human primates in their home environment, in their social group? And are these long-term functional alterations accompanied by long-term structural changes that are evident in the brains at this age after early in life anesthesia exposure. To approach these questions, postnatal day 6 non-human primates were exposed to isoflurane for 5 hours, either 1 or 3 times on postnatal day 6, 9, and 12, while controls were exposed to oxygen only. So there were total 3 groups. After being housed with their dams in the first year, the animals were weaned and transferred into new social groups at 1 year of age. During the total 2-year life period, repeated tests of cognition and behavior have been carried out. And at 2 years of age, an age that is comparable to 6 to 8-year-old human children, so school-aged children, the animals were assessed by focal observations in their so-called home cage. To address our second question regarding accompanying long-term structural alterations, the animals were euthanized and their brains were prepared for histopathological analysis. To assess the animals' spontaneous behaviors in their social environment, we used focal observation, meaning an experienced investigator who was familiar to the animals conducted 10-minute focal observations 2 to 3 times per week for a total of 3 weeks. What was measured was the time the animals spent in one of the behaviors displayed here: close social behavior, aggressive behavior, anxiety, or appeasement behavior. The analysis of these observations revealed that the animals that were exposed to isoflurane during infancy spent less time in close social contact compared to the controls. Close social behavior was defined as behaviors like grooming or huddling or just being closer than 1 arm length to another animal. So these animals that were exposed to anesthesia during infancy were somewhat isolated and preferred to be alone. To address our second question, we decided to look for astrogliosis in the animals' brains, since brain injuries of other causes have been associated with astrogliosis, namely chronic astrocyte activation. Astrogliosis is a common response to several types of brain injuries, including trauma, ischemia, and neurodegenerative conditions like Alzheimer's disease. And astrogliosis can be identified by increased expression of glial fibrillary acidic protein, short GFAP, which is a cytoskeletal protein in astrocyte that remains chronically elevated after the brain injury. Based on previous studies that investigated brain areas indicating an acute injury, such as increased rates of apoptosis after early in life anesthesia exposure, we first analyzed GFAP densities in the primary visual cortex, also called V1. And as you can see, comparing GFAP densities, we found that 2 years after anesthesia exposure, animals showed increased GFAP densities, increased astrogliosis in V1. Based on our findings of alterations in social behaviors, we next analyzed GFAP in the amygdala, a major hub for the processing of social behaviors. And plotting the resulting GFAP densities of the 3 groups, we found that compared to the controls, the GFAP densities were increased 2 years after anesthesia exposure. So in summary, we found that 2 years after anesthesia exposure during infancy, the juvenile non-human primates showed decreased close social behavior when they were observed in their home environment. And at the same age, the brains of the exposed non-human primates display astrogliosis in the amygdala, a brain area that is strongly involved in the processing of social behaviors. Importantly, the functional alterations that we found in the juvenile non-human primates parallel the findings in recent clinical studies that reported behavioral alterations in the assessment of exposed children in their home or their school environment. Together with the structural alterations in the amygdala, namely the astrogliosis, our studies indicate that anesthesia exposure early in life might impair the social development and behaviors of the exposed individuals. So our future directions will focus on investigating the social development in individuals exposed to anesthesia early in life and using the non-human primate model as this being the closest to the humans in terms of brain development and behavioral repertoire. And with this short comment on our future directions, I would like to end, and I would like to thank the Department of Anesthesiology at Columbia University and its chair, Dr. Ansgar Brambrink, who is also the head of this research, and my colleague, Jose Perez-Zogby, with whom together I did all these studies. And I also want to thank our collaborators at the National Research Primate Center in Oregon and our collaborating expert in neuropathology at OHSU. And of course, I want to thank you for your attention and your interest in our research. Thank you very much.
My name is Caleb Ng, and today I'll be speaking about a behavioral phenotype in clinical studies of anesthetic neurotoxicity. I do have some funding, but I have no other financial relationships to disclose. So if you were to look at many of the review articles and the editorials that summarize the clinical evidence of anesthetic neurotoxicity, many of them will say that the results are mixed or ambiguous or unclear. And the reality is that it's complicated. There have been over 100 clinical studies that have been published evaluating neurodevelopmental outcomes following exposure to anesthesia in children. Hundreds of different outcomes and outcome scores have been used. And there have been many different patient populations that have been evaluated, including different types of procedures, numbers of exposures, ages of exposure, and ages of evaluation. So I'm going to talk a little bit about some of the studies that have been published and some of the heterogeneity between the studies evaluating behavioral problems. The first study that evaluated behavioral problems in anesthetic exposed children was one looking at monozygotic twins where they're exposed under the age of 3 years old and matched to twins who are unexposed. They looked at the Conners teacher rating scale, which evaluated externalizing behavioral problems and found no difference at 12 years. Stratman published a study in 2014 where they evaluated 28 children exposed under the age of 1 year compared to 28 children unexposed and found no difference in the child behavior checklist, which is a commonly used survey filled out by caregivers evaluating behavioral problems in their children. So those two studies found no difference, but you contrast that with these two more recent studies published in 2015, looking at 35 children who had multiple exposures compared to 35 healthy unexposed children enrolled from a vaccination clinic. And what they found was that by using the CBCL 1.5 to 5 year assessment, so the CBCL adapted for younger ages, these children who are exposed with multiple exposures had 11 times the increased rate of having anxiety and depression problems as the unexposed children, and 8 times the increased rate of having attention problems. Another study in 2019 by Coach Fee evaluated kids who had a general anesthetic at their institution versus a regional anesthetic, and they used the IBER Child Behavior Inventory Questionnaire, which also evaluates externalizing behavioral problems. And what they found was that the kids with a general anesthetic had a 7 times increased odds of having behavioral abnormalities. So you have 2 studies finding no difference and 2 studies finding a major effect. So how do you interpret that? So we recognize that there is so much heterogeneity in the literature that we tried to perform a meta-analysis to try to interpret the results. We tried to focus on the clinical neurotoxicity studies that we felt were using the most comprehensive battery of assessments and performed prospective outcome assessment. And the reason why we did the focused on prospective outcome assessment were that these studies allowed the designing of batteries to involve the most sensitive outcomes, and also allowed for the review of clinical data in order to minimize confounding in that these children were physically evaluated by the researchers. We focused on single anesthetic exposures and excluded children who were participating in studies of major chronic conditions, specifically studies evaluating kids with major congenital heart surgery or prematurity. And by using these inclusion and exclusion criteria, we found 3 studies that met criteria and had overlapping outcomes. These 3 studies were the PANDA study, which is a multi-center ambidirectional study evaluating kids who had hernia surgery under the age of 3 compared to siblings who didn't. The MASK study, which is a single center ambidirectional study evaluating kids who had various surgeries under the age of 3 compared to kids from the community who didn't have anesthesia or surgery. And these are both observational studies. And finally, the GAS trial, which is unique because it's the only international blinded randomized controlled trial that's been performed evaluating this question, where they randomized kids to having sevoflurane general anesthesia compared to kids who had hernias under awake regional anesthesia without sevoflurane. So when combining the data from all 3 studies, what we found was that there are 5 outcomes that they had in common. The first was intelligence as measured by IQ. We found no difference in IQ scores with a single exposure in these 3 studies. And here you can see that the I-squared is 0, which means that there's very little heterogeneity between the study results. And you can see that the results are completely overlapping between the 3 studies. The next score was the CBCL, which is composed of the total behavioral problem score, the externalizing behavioral problem score, which evaluates externalizing problems such as disruptive behavior and ADHD, the internalizing behavioral problem score, which evaluates problems such as anxiety and depression. And in this CBCL assessment, what we found was that there are higher or worse behavioral scores after a single exposure of about 2 points, and that the size of the association was similar in all 3 studies, with I-squareds of 0 showing very little heterogeneity between the study results. Finally, we evaluated the brief, which evaluates executive function problems. And in this assessment, there are higher or worse executive function scores. However, this wasn't statistically significant after multiple comparisons adjustment. And also there's a little bit more heterogeneity in this result compared to the other behavior and intelligence scores. So the take-home points from this are that it seems that the behavioral results from studies using prospective data are a little bit more consistent than some of the other studies that have been published using pre-existing observational data. In interpreting this 2-point difference, we did a secondary analysis and we found that this was associated with about a 47% increase risk in internalizing behavioral problem in exposed children, which is far lower than the 7- or 8-fold reported in some of the other studies. And finally, that there are associations seen in some of the outcomes, such as behavior, but not in some of the others, like intelligence. So how does this compare to other studies? So this is another study that evaluated behavior in addition to a range of other neurodevelopmental outcomes in children from Southwest England, born from 1991 to 1992, where there are 1,000 kids with a single exposure and 200 kids with multiple exposures compared to a large group of children with no exposure. And in this study, they evaluated a range of different outcomes and found differences in socio-behavioral outcomes with a single exposure, as well as multiple exposure, some motor differences with single and multiple exposure, as well as some differences in language here with a single exposure. But they didn't find any differences with these educational or cognitive outcomes. We did a study recently looking at prenatal exposures. And the reason why we did this is that what's unique about prenatal exposures is most postnatal exposures stemmed from the child's medical issue, which requires the child to have some type of surgery and anesthesia. However, with prenatal exposures, it's a little bit different because the exposure is due to a need in the mother and not the medical condition in the child. The limitation of looking at prenatal exposures is that they're quite rare. In this cohort of about 2,000 kids, we only found 22 kids with a prenatal exposure. But in evaluating these kids, what we found was that their scores for behavioral problems were much worse, 6 points worse than the kids who were unexposed. However, this difference was isolated to externalizing behavioral problems, and we didn't find any differences in the other neuropsychological tests. Incidentally, this cohort was also evaluated for postnatal exposures under the age of 3 years old, and no differences in CBCL were found, but there were differences in language and abstract reasoning with the postnatal exposures. So I guess the take home from these two studies looking at a wide range of different outcomes is, again, that associations are seen in some outcomes, but not others. So it's likely that if behavioral problems actually do exist, then they don't exist in isolation because problems, neurodevelopmental problems usually co-occur with other problems. And one of the issues that commonly occurs with behavioral deficits is a diagnosis of ADHD, particularly if kids have externalizing behavioral problems. So there have been a number of studies that have evaluated ADHD. And these 3 studies found ADHD only associated with multiple exposures. We performed a study using children in Medicaid, finding that with a large cohort of about 40,000 exposed kids, there was an increased risk of ADHD and ADHD medication use with a single exposure. And this study, looking at 30,000 kids, found there's, again, an increased risk of ADHD diagnosis with single and multiple exposure. And when you try to look at the consistency between the studies, you can see that overall, a single exposure is associated with about a 30 to 40% increased risk of ADHD, and multiple exposure is associated with a higher risk of ADHD. So to try to summarize and talk about where we go from here, there is some significant heterogeneity in the clinical studies. Some studies have found that exposure to anesthesia is associated with deficits in only specific neurodevelopmental domains, and behavioral problems is one of them. Nearly all of the studies are observational in nature and almost certainly have some level of unmeasured confounding, and as a result, the deficits we see may still not be due to anesthesia specifically, but could be due to another factor. If behavioral problems are present, they likely co-occur with other deficits. So we may want to look at some other potential deficits that are likely to occur with behavioral problems if we want to evaluate behavior. And finally, if we want to try to assess whether or not anesthesia really causes problems in children, we will need more observational studies and likely randomized controlled trials in the future. Thank you for your attention, and I'm happy to take any questions.
Well, good afternoon or good morning, everyone. I'm Dean Andropoulos, the SmartTots medical officer. Just want to share my screen for a couple of minutes to talk about some SmartTots initiatives, and then we'll get to questions. Just to remind everybody, SmartTots is a public-private partnership between the IARS and the FDA, whose goal is to make anesthesia safer for infants and children, also to organize high-quality seminars and panels at IARS and other meetings, to author and have published reviews and white papers, coordinate and fund research, and facilitate education and messaging to stakeholders, including anesthesia practitioners, parents, patients, and the public. As an example, this review article was just published in Anesthesiology. This is a SmartTots review article, Anesthesia and Developing Brains, Unanswered Questions and Proposed Paths Forward. Caleb Ng, who you just heard, is the primary author and organizer of this group of experts, and This, I think, if I do say so myself, is well written, and if you're interested, I highly recommend this review article. Also, SmartTots has a request for proposals for $250,000 in funding for one or more research grants. The deadline passed a couple of weeks ago, but we have 15 excellent proposals addressing anesthetic neurotoxicity and developing nervous system in platforms including tissue culture, small animal imaging, human studies with neurodevelopmental outcomes, and the drugs studied include, or proposed to be studied, are volatile anesthetics, dexmedetomidine, ketamine, and propofol. The study section is May the 16th, so look for more information about that. Finally, I want to thank our fantastic speakers for excellent talks. Just briefly by way of introduction, Dr. Vesna Jevtovic-Todorovic is the chair of anesthesia at the University of Colorado and the author of one of the seminal papers in anesthetic neurotoxicity published in 2003 that really sparked great interest and initiated research in this field. Dr. Ashok Panigrahi is radiologist in chief at the Children's Hospital of Pittsburgh and one of the leading experts in the world on neonatal and pediatric neuro imaging, especially quantitative neuroimaging by MRI. Dr. Viola Neudecker is an associate research scientist in the Department of Anesthesiology at Columbia, where she studies the effects of anesthetics on the infant brain using the non-human primate model in the research group of Dr. Ansgar Brambrink. And then finally, Dr. Caleb Ng is a pediatric anesthesiologist and an associate professor of anesthesiology at Columbia University. So without further ado, I would like to get to questions. Please type your questions into the chat is the best way to do this, and I'll read them and direct them to our speakers. And I have a few questions of my own if there aren't questions. So Jingjae says, and I think this may be primarily to Ashok, does anyone have data using fMRI in humans?
In terms of neonates and infants, I haven't seen published studies. Part of our data set, I showed mostly DTI data. We do actually have some resting state data in some of these patients who've had research MRIs. So that would be something we'll be able to look at, but I'm not aware of any specific functional MRI studies in newborns related to anesthesia neurotoxicity.
Thank you. I have a question. I don't see any additional questions. This is a question for both Viola and Vesna. So preclinical animal studies, both in rodents and to some extent in non-human primates, have been criticized for either lack of physiological monitoring or the standards for physiological monitoring, and that hypoxia, for example, due to respiratory depression from the drugs could be leading to brain injury and mortality. What's the response to that? And maybe Vesna can address that first, and then Viola. How in your experiments are you addressing this criticism?
Thanks, Dean. This is a tremendous honor to be here. Viola can probably address that better in larger animals. In small animals, we do struggle with that. We've been using pulse oximetry. That has been very useful. Also, in some of the initial studies we did blood gas analysis, as you know, but that calls for transcardiac puncture because that's the only way to get arterial sample. So not really a good way to address that in an animal that's only 15 grams. We've done a lot of work, as you know, with guinea pigs. And in guinea pigs, this is synaptogenesis is in utero phenomenon. So we totally lined up a mother with A-line and IV and blood pressure measurement and blood gas. And we found absolutely no changes in any of these parameters. And yet the fetuses still had quite a bit of damage. But you're right, it is always an issue. Viola, you may have a better solution to that since you're working with bigger animals.
We can't hear you, Viola. I can't, at least.
We can't hear.
Okay,
Maybe you have a mute button pressed on your computer. Maybe you can check that.
Yeah, maybe I'm going to go on to another question while we figure out the sound, but that is an important question. And then let's see. We'll go to Misha Paransky in the chat. Trajectory of new drug development. In 40 years between halothane in the 2003 paper, 20 more years until we have data that there are probably are behavioral consequences. How long will it take until we realize that new drugs also have collateral effects on the fragile brain? So for any one of the panelists can take that question. That's an important question.
You know, it's a typical Misha's question and really a great one. Yes, we've been kind of watching and studying for 20 plus years. And the question for us is, what is going to convince us that it's time to look at it differently? And I really believe that we owe that to our children, not to anesthetize them, but to provide them with better anesthetics with the focus on neurotoxicity, something we didn't do 30 years ago when new drugs were developed. I mean, if you look at any other field, it's developing all the time. And yet for us, it's taking decades to come around. Very good question, Misha, actually. I've been pondering that myself.
Viola, let's see if you have sound. Okay, apparently not. So I know from reading your papers extremely carefully that the neonatal rhesus monkey is about the size of a premature infant. And I know that you guys have full physiologic monitoring and are providing an anesthetic exactly as you would to the newborn infant: blood pressure, EKG, oxygen saturation, and so on. And you're carefully monitoring the research subjects. And I know that this is well controlled and you have not had any major perturbations. And so I think that at least for the neonatal non-human primate model, the monitoring is excellent. So that's what I have gleaned from all of your excellent research.
Yeah, thank you. Did you hear me now? No.
Yes, yes.
Yeah. Oh, you hear me. Okay. Yeah, this was a very good summary. Yeah, that's actually the reason why I think these non-human primate models are of such high value, despite some other advantages. But being able to really mimic the pediatric OR situation is making every result, every outcome that we get so much more valuable, because we can kind of discard the criticism for the small animal models. However, these studies are very expensive, so it's clear that that small animal models, rodent models, are still important. But I think that this major criticism can be well addressed in non-human primates.
Great, thank you. Question for Dr. Ng. Caleb, can you give a sense of the magnitude of the values on the behavioral scales? What are the standard deviations from the norms? That's from David Polliner. Oh, and by the way, we have a 10-minute extension until 1:40 Central Time, or 10 more minutes, because we started a little bit late. So Caleb, go ahead, please.
Sure. So that's a great question. When you look at least the meta-analysis we did, we saw that there's a 2-point difference in the CBCL scores, and about a 2-point difference in the brief. And what exactly does that mean? The brief and CBCL, this one standard deviation difference is 10. So this would be a 0.2, around a 0.2 standard deviation difference in the score. And even that, it's hard to understand what that really means clinically. So what we did was we looked to see what a 2-point change, or specifically in those studies, what that means in terms of moving kids past a clinical threshold. And we set the clinical threshold as a score that was at least 1 standard deviation worse than the mean, which what that translates to is having scores that are about 16 in the 16th percentile, the lowest 16th percentile of all scores. So in trying to figure out the percentage of kids who had those lowest scores in the lowest 16th percentile of scores, we found a 40% increase or 50% increase in kids. So just to kind of summarize, a 2-point difference in these behavioral outcomes translates to about a 40 to 50% increased risk of being in this clinical threshold of deficit.
Thank you very much. Let's see, I have a question for Ashok, actually. So as you showed in the preliminary data, MRI microstructural and macrostructural abnormalities do have some correlation in that group with later neurodevelopmental outcomes. So what is the data say in other groups, maybe premature infants or others, that slow DTI trajectory or other microstructural abnormalities are associated with later problems in neurodevelopment in preemies or some other group that's been studied? I mean, people are going to ask, well, what does this really mean to long-term?
Yeah, I think that the preterm world has been doing longitudinal studies for a while. I think Terry Inder has a population that she's been following for almost 15 years now longitudinally. And I think we see similar relationships between microstructure and macrostructure, and also short and longer term outcome, and similar risk factors specific more to prematurity.
Thanks. And just as a quick follow-up, for an unsedated infant MRI, how successful, and what is the percentage, say, in a, let's say, a 6-month-old who you put in the scanner? Is it 90%? Is it, I mean, how successful? Let's just take a 6-month-old because there are a lot of ages. How successful in your hands is an unsedated research MRI?
You know, this is a moving target at some level, because it does come down to experience and doing some pre-sensitization and preparation for the feed and bundle. It does get, I would say we are able to do 80 to 90% successful scans with feed and bundle up to about 3 months. 3 to 4 months, it gets a little bit harder. You may consider doing more evening scans or finding better times that you know that you can, when the baby is actually going to sleep. And then the other thing too is that our technology is changing. We're developing faster and faster sequences, which is very exciting because we'll be able to do more advanced sequences faster and then do more of this research imaging in a larger group without losing lots of cases.
Great, thank you. A question from Dianshi Wang, I think to Viola. May I ask the rationale for 5-hour ISO exposure to non-human primates? And what is that equivalent to an infant?
Yeah, so the 5 hours initially were indicated by the early studies looking at the acute injury. So 5 hours were producing a robust apoptosis increase in the brains of these animals. And then from another point of view, looking at behaviors, we know from human studies that we need quite high numbers to detect these subtle effects that anesthesia early in life causes. So it was kind of also the idea that we want to be able to really see these subtle effects with this low number of animals that we usually only have for non-human primate studies. And that study was 8 animals per group. So it was kind of the idea that we want to see that the anesthesia exposure causing effects, but this is very difficult to compare to humans. I think in general, thinking of the difference in time, like these 2-year-old non-human primates were juveniles already, while in humans 2 years is, so it's very difficult to I think to find a way to calculate this back or forth. It's more the idea to see what effects does anesthesia early life cause, so we can go back and try to screen kids for these alterations, rather than trying to find the equivalent, because there is a range of exposure durations, and maybe this will model only the very long exposures. However, if we find what anesthesia per se does at this age, we can, yeah, like I said, just screen for these type of behavioral alterations, and it doesn't really matter in the end whether we expose the animals 5 or 2 hours, but we need to know what is the characterized, or what is the phenotype that it's causing.
Thank you. And then question from Misha Perwansky to everyone. Would you consider that detrimental outcomes may not be universal, but determined by genetic background, that genetically predispositioned kids have particularly bad outcomes that drive the average modest changes? Excellent question. Anybody on the panel, please take a shot at that one.
You know, we looked at epigenetic changes that occur post-anesthesia exposure, and going back to Misha's question, that's an excellent question, Misha. We found actually that the offspring of mothers exposed to anesthesia actually do show epigenetic changes in a second generation offspring. So there's also a study from mid-80s, if you want to look at that one, that looks at behavior and finds that the offspring never exposed to anesthesia, but who came from mothers that were exposed actually have learning deficits. So genetics, I don't know much about that, but epigenetics definitely has a huge role. In particular, DNA methylation and histone acetylation is what we've seen. So I don't know, Misha, whether that answers your question, but definitely there is an element of that.
Caleb, any thoughts about that?
Sure. Yeah. So I think that this is a great question. This is a question about, is there a vulnerable population of children? I think that certainly there very likely may be. If you look at other populations of children or other populations that have had neurotoxin exposures, there are certainly predisposing factors that make a child more vulnerable. One that's, I know off the top of my head, that's been evaluated is socioeconomic status and lead. Children from lower socioeconomic strata are definitely more likely to experience deficits after a lead toxic exposure. And I think that maybe genetics or other medical comorbidities could also play roles. I don't think that we necessarily have answers to that, but it is an important question.
Great. We're coming up upon the end here. I do see a previous question. Where are we in the SIVO and DEX trial? That means T-Rex. I think I can answer that. So that trial needs to enroll 450. It's a multi-center international trial, has enrolled over 300 so far, and maybe 100 have received the neurodevelopmental testing. It's going to take several more years for that trial to be finished. For the panel, if your kid needs anesthesia, what drugs or combinations are considered safe to use, if any? And speaking as a clinical anesthesiologist involved in the research and in my SmartTots role doing cases, I have not changed my clinical practice yet to this point at all. There's no sufficient data, to my view, to choose one regimen over another. This is the purpose of the T-Rex trial. I don't know if any of the others have changed what they do on a daily basis because of any of this research right now, if they're not in if the patient is not in a research trial. Caleb, Vesna.
No, I agree with you that there's not enough data to suggest that there should be something to change it to. So if we were to change it, I would say that there isn't necessarily evidence to back it up.
But I don't know how long it's going to take to get there, right? What are we looking for exactly? How complex that is to look at and discover. I mean, you look at MRI data, they're scary for me, honestly. And it's coming from a colleague who has no horse in that race in many ways. So you look at oncologists, peds oncologists, and the data they are showing over the last couple of years, it is scary. And, we can talk about is 5 hours too long or too short, but at the end of the day, we have to serve the sickest patients that we take care of, and they deserve the best possible care so we can protect their development. So you know how I feel about it.
So maybe we're going to end, they may cut us off here, but Vesna, what is next for 3-beta hydroxy? What's next? It looks very promising, very comprehensive study. So what is next if we say we want to bring that drug to the operating room?
Yeah, Dean, and Viola knows we've actually teamed up with Columbia University and Dr. Ansgar Brembrick to take it to the non-human primate. And we've been working with Oregon Primate Center as well, trying to figure it out. The problem with these drugs is that they are very difficult to dissolve. So to go from here to through pharmaceuticals is going to take some doing. But yes, Dean, that's the next step for us. Is it safe? Could it be used in monkeys? And what do we do with that? You know, that's in my mind the next. I really do think we need to start developing something new, regardless of how convinced. I mean, we stopped putting lead in the paint. Do we have a proof beyond reasonable doubt that that's what's doing it? No, but why expose kids to lead if there's any association whatsoever? Here, this is slightly different, but in many ways, not that different.
On that note, I want to thank the speakers again for your time and expertise, for wonderful talks, and thanks for the attendees and the great questions. Enjoy the rest of the meeting, and we certainly hope to see everybody in person next year at the IARS, and hope that COVID will be low, maybe not under control, but very low for the foreseeable future. Let's hope. So thank you again very much, and please, everybody, enjoy the rest of your day. Thanks a lot. Bye-bye.